So basically, you all are prepared already. So genetics is something which is very volatile. So my only endeavor is to get you into the groove for genetics for MRCP, number one. Number two, to catch hold of almost everything which is important for the exam. Number three, not to miss out on something which is important. That is also very, important for the exam. So we will just touch upon few topics. We'll just briefly try to understand them because in such a short span of time, whole of the genetics and the diseases associated with it, it becomes very difficult. So as far as the genetics goes, oh, you need to understand that in genetics you will get number one, the genetic basis of disease. This is the concept that is asked in the exam, number one. Number two, how to diagnose genetic diseases. And number three, which is a very weird thing, it is how to treat genetic diseases. And number four is miscellaneous. Miscellaneous is like pharmacogenetics, then screening for genetic disorders. Like every country will have their own set of recommendations and guidelines as to how to screen for genetic diseases. So just this, with this generic background, I would like to ask randomly, can anybody tell me what is the genetic basis of a disease? Broadly speaking, why it is important for us to understand the genetic basis of a disease? See, some diseases, they are inherited as a genetic disorder. Now, this is one. Number two is certain people are prone to certain diseases because they have genetic deficiencies. For example, G6PD deficiency. This is also a genetic disorder. Like some people who are hemophiliacs, they have genetic disorders, so they're more prone to develop bleeding disorders. Number three, certain cancers, they are more common in certain genetic disorders. Number four, certain structural diseases are more common in certain genetic disorders. So we as doctors, we have the responsibility to ascertain if somebody is carrying a gene or a chromosome which can affect the offspring or their own life in a particularly wrong fashion. Then comes diagnosis. Can anybody tell me how do you diagnose genetic diseases? Am I audible? All I'm asking is if somebody can tell me how do you diagnose genetic diseases. You are preparing for MRCP exam. You already have certain amount of knowledge because all of you are doctors. So my question to all of you is how do you diagnose genetic diseases? Anyone? Okay,
By
so you will,
just
yeah.
screening the genetic deficiency, the genes, what we mentioned.
Yeah, how do we diagnose these genes? What is the mechanism? Like like we order sodium, potassium, urea, creatinine, CBC, total blood count, LFT. What do we say that we want to get a genetic disorder tested?
The genetic mapping.
So we do a karyotyping
Yes.
and gene analysis. This is what is done these days. So you will enjoy this class uh, after having these questions in mind. Then, of course, how do you treat genetic disorders? That is another thing. And then we will see the miscellaneous pharmacology. Miscellaneous pharmacology means certain uh, enzymes, they are inherited and they have different, fast acetylators and slow acetylators. These are all genetics. Okay. So let's begin the topic with the biggest chunk of the genetic disorders, that is autosomal dominant disorders. Now, I always tell my students that there are two types of disorders as far as autosomal genes are concerned, which are autosomal dominant and autosomal recessive. The autosomal dominant diseases are more or less structural diseases. So wherever you will find a structural disease, no, there are high chances that the patient will have a autosomal dominant disorder. Then comes autosomal recessive disorders. Autosomal recessive disorders, they usually manifest as enzymes or chemical related processes deficiency. So they will have like some enzyme deficiencies are usually autosomal. Wherever it is a biochemical process related with it, it usually is autosomal recessive disorder. So let's begin our journey for genetics by autosomal disorders. So all you need is one mutated copy. So we all know that there are two chromosomes. So genes are present on both of them. One is from the father, one is from the mother. So all you need is a major uh, single gene which is altered and it will manifest as a disease. A one mutated copy of a gene is sufficient. For example, A, this is a normal genotype. A, this is female, this is male. They marry, so everybody has A. We understand that. But now let us say the gene is so dominant that this gene became mutated. So we have A dash A and AA. So A dash A will be diseased. That means you will never have a carrier. Never a carrier. Why? Because even a single copy is sufficient for the disease to manifest. Hence, there will be no carriers in autosomal dominant disorder because the genetic defect is a dominant defect. Even if it is singly present, it will definitely cause the disease. Common examples are Huntington's chorea, Marfan's syndrome, familial hypercholesterolemia. So, let us go through the case scenarios to understand the process in a better manner. A 28-year-old man with a family history of sudden cardiac death is diagnosed with aortic root dilatation on echocardiogram. He is tall, he has long fingers, and there is a chest deformity known as pectus excavatum. What is the most likely disorder in this patient? Ehlers-Danlos syndrome, Marfan syndrome, Turner syndrome, or Loeys-Dietz syndrome?
Marfan.
Yeah.
Marfan's.
So this is Marfan's syndrome. How do you say that? Why not Ehlers-Danlos?
Cardiac defect, I think, is only for Marfan's.
Say again. Pectus
The cardiac,
excavatum.
the cardiac defect is not seen in Ehlers, I think.
Yeah. So aortic root dilatation, very aptly picked up. So aortic root dilatation is usually seen in this Marfan syndrome. Okay. So if I had to pick up something for Ehlers-Danlos syndrome, then what would it be? Because both of them, they manifest very, very similarly.
The lens subluxation will be
Wonderful. So lenticular subluxation. So if there was mentioned that there is a history of a repeated blurring of vision for which the patient has been diagnosed with some lens related issue, this will be Ehlers-Danlos. Okay. So this patient has Marfan syndrome. We will come to it that there is a mutation in specific gene known as fibrillin-1 gene, which is FBN1 gene, characterized by, as you said, aortic root disease, tall stature, and skeletal abnormality. Tall stature and skeletal abnormality, hyperreflexia, hyperlaxity, these are seen in other connective tissue disorders also, but aortic root dilatation is specific for Marfan syndrome. Okay. Can anybody tell me why Turner syndrome is specifically mentioned as a choice in this question? Now, as a student, you need to read the examiner's mind also. Why Turner syndrome is kept in this?
Because
Because
Yeah, they also have some cardiac related issues, is it?
Do they have a tall stature?
No.
Are they not tall? Turner syndrome? Turner is what, XO?
Yeah, 45 XO.
Yeah, so they are usually tall people, but they have aortic root issues. What are those issues they have?
The
So they usually
coarctation
have
of aorta.
coarctation of aorta. Yeah. So they have coarctation of aorta. So when you have similar two things in a question, then there are chances that some children, some student who have partial knowledge, they might pick up that answer. So it is important for you to differentiate. Every single word is important. In MRCP exam, nothing is taken for granted. All right. So the answer here is Marfan syndrome. A 45-year-old man with LDL. Okay. When I was telling you about the autosomal dominant disorders being structurally more, bent, that they are usually structural diseases, this brings to our mind, is there any non-structural disease which is autosomal dominant? Yes, it is hypercholesterolemia, familial hypercholesterolemia. So please remember that. And when I come to the autosomal recessive, I'll tell you some autosomal recessive diseases which manifest as structural diseases. They are exceptions. This is an exception. That is why I specifically kept it. A 45-year-old man with LDL of more than 250 milligram per deciliter has tendon lymphomas and a family history of premature coronary artery disease. What is the inheritance pattern for this condition? This is a specific question, has appeared in the exam so many times because
Autosomal dominant.
yes, so you will need to remember
Familiar
that
hypercholesterolemia.
yes, that familial hypercholesterolemia, although it is a metabolic disorder, but it is autosomal dominant. This is a rare thing. So familial hypercholesterolemia, it follows an autosomal dominant inheritance, severe LDL elevation, and early cardiovascular events. So this brings us to a discussion on autosomal dominant inheritance. What do we need here is a single copy is sufficient to cause the disease. A mutation in one allele of the gene is enough to cause the disease. Second, it has vertical transmission. Why? Because all the diseases will travel from parents to the children. Of course, every diseases, genetic diseases travel like this, but vertical transmission means the disease definitely will travel from the upper generation to the lower one. Equal gender distribution. There are no distinction between genders as far as autosomal diseases are concerned. We will come to that. 50% recurrence risk. An affected parents has a 50% chance of passing the mutation. These lines, they have come in the exam as ditto. 50% recurrence risk is seen in autosomal dominant disorder. What kind of disorders? Usually structural, like neurological disorder, Huntington's disease, neurofibromatosis, tuberous sclerosis. These are basically structural. You can say that, like in neurofibromatosis, there are tumors of the peripheral nerves, neurofibrillin 1 associated with cafeola spots, again something structure related, and Lish nodules, again structure related, something to do with the morphology. Tuberous sclerosis, there are facial angiofibromas, patients have seizures, and renal angiomyolipomas. Then skeletal and connective tissue disorders, like you perfectly picked up, Marfan syndrome. There is fibrillin 1 mutation, tall stature, aortic aneurysms, ectopia lentis, usually seen in Ehlers-Danlos. Ehlers-Danlos, hyperextensible skin and joint hypermobility. Achondroplasia, structural, short-sighted people. FGFR3 mutations, short stature due to defective endochondral ossification. Osteogenesis imperfecta, structural disease. Colia 1, Colia 2 mutations, brittle bones, blue sclera. Has somebody seen this movie called Dune? In that movie, there is a set of people who have, everybody has blue sclera. So this is how osteogenesis imperfecta people with blue sclera look like. Hematological disorder, hereditary spherocytosis, again structural, structure of the RBC is distorted, leads to hemolytic anemia. Disease is because of spectrin or ankyrin protein defects, which are important integral proteins. Von Willebrand disease, deficiency or dysfunction of von Willebrand factor. Cardiovascular diseases like hypertrophic cardiomyopathy. This is so important. HCM has a autosomal dominant inheritance pattern. Familiar hypercholesterolemia. Then other disorders, very famous ADPKD, PKD1, PKD2 mutations, familial adenomatous polyposis, APC gene mutation, numerous colonic polyps, retinoblastoma, RB1, eye tumors in gene, multiple endocrine neoplasia, where there are several type 1, 2A, 2B, and tumors of endocrine gland. Important points in autosomal dominant are there are variable penetrance. Some individuals with that mutation may not express the phenotype. So theoretically speaking, A-A should have the disease, but the penetrance may be variable. That means they will not manifest into the 100%. That totally depends on the degree of mutation in the genes. So genes also have a long pool of these nucleotides and nucleosides repeating. So sometimes, although the gene is mutated, but the type of mutation is different in each gene. De novo mutations can also occur without any family history. There is anticipation, that is, successively in down generations, the disease occurs early in age. For example, let us say in the first generation, it was 60 years. Second generation, the disease started at 50 years. In third generation, probably it started at 28 years. Specifically in Huntington's disease, hypertrophic cardiomyopathy, people can have disease at a younger age when they are inheriting this. So autosomal dominant inheritance, again, let us review. So single copy is sufficient, vertical transmission is there, equal gender distribution, and there's a 50% risk of carrying the disease. Then there is a variable penetrance, anticipation is seen. Although it's a genetic disorder, but de novo mutation will also manifest. Why? We understand it's an autosomal dominant one. So even if one gene gets mutated, the disease will manifest for 100%. Maybe it is less symptomatic or more symptomatic. That is not the point. But if one gene gets mutated either by inheritance or spontaneously, now coming to autosomal recessive disorders. The problem here is it is a recessive disease. So two genes, two are needed to tango. So both alleles of the gene must be mutated for the disease expression. For example, A-A will be a carrier. He will not be symptomatic. A-A will be symptomatic. For both the alleles of the gene must be mutated for disease expression. If just one gene is mutated, it will be a carrier. So two carriers have to marry to produce one diseased child. So there comes the role of genetic counseling and genetic screening. So these are the diseases that you should keep in mind, not for the knowledge of these diseases, but to prevent and counsel the patients so that these diseases they don't get transferred in future. So the knowledge of these diseases is important, that you start looking for any elder in the family with similar symptoms so that you can tell that okay, nowadays people get married out of genetic counseling as well. We will come to that point where the nice guidelines and the NHS related rules regarding genetic screening and genetic analysis is concerned. Common examples, enzymatic diseases like cystic fibrosis, sickle cell anemia, phenylketonuria. So, a 3-year-old child has recurrent pulmonary infections, failure to thrive, and bulky, greasy stools. Sweat chloride testing confirms the diagnosis. What is the genetic mutation responsible for this condition? What is the diagnosis?
Cystic fibrosis.
And which is the gene involved?
CFTR.
CFTR. And which is the chromosome on which it is present?
Chromosome 6, sir.
Chromosome
6.
6. Okay. I thought it was chromosome. Okay. So, cystic fibrosis is an autosomal recessive disorder and it is caused by the mutations in the CFTR gene, leading to impaired chloride transport and thick mucus production. So, they have stagnation of the thick mucus in almost all the tubes of the body, be it lungs, where bronchoria leads to plugging of the bronchi, uh, pancreatic ducts, where pancreatic secretions they dry out, become thick, and block the pancreatic duct, leading to pancreatitis, which is a recurrent pancreatitis. They are chronically constipated because again the same process happens in intestines. They also have infertility issues because in the fallopian tubes the secretions plug in the fallopian tubes. They are not accessible for the uh, this fertilization to happen. And same stands true for the males, where sperms get occluded in the testicular ductal system, whereby there is a plugging by the mucus and all. So, cystic fibrosis is so important. How do you diagnose cystic fibrosis, anyone?
Sweat chloride test.
So, yeah, sweat chloride test is important, which is sweat test, which is a gold standard for the diagnosis. So, CFTR gene is important. And it is autosomal recessive disorder. Okay. A 6-year-old boy. This is the autosomal recessive gene with an exception because it is a structural disease known as sickle cell anemia. Okay. So a 6-year-old boy, African ancestry, presents with fatigue, jaundice, and painful swelling of his hands and feet. HB electrophoresis shows presence of hemoglobin S. What is the mode of inheritance and what is the disease? So what is the disease? Sickle cell anemia. What is the mode of inheritance?
Autosomal recessive.
So autosomal recessive. What is this painful swelling of hand and feet?
Sickle cell crisis.
So there are several types of sickle cell crisis. This is acute occlusive crisis. Okay? Yeah. So mutation of the beta globin gene. So can anyone tell me about sickle cell disease?
Yeah, beta chain of hemoglobinopathy. There is a change in the beta chain of hemoglobin. Valine will be replaced by the glutamic acid in the sixth position of beta chain of hemoglobin.
Which chromosome? So it is what kind of mutation it is it? It's a,
Autosomal recessive point mutation.
it is a point mutation. So what happens is there is a nucleotide substitution, as you said. Glutamic acid is replaced with. So let's venture into the autosomal recessive inheritance. As I told you, 2 copies will always be required. Both alleles of the genes must carry mutations to cause the disorder. There is a horizontal transmission, unlike in autosomal dominant, where autosomal dominant is a vertical transmission. In autosomal recessive, there is a horizontal transmission. Then there is presence of carrier parents. And what is the recurrence risk? 2 carrier parents have how much chances of transfer? Only 25%. Whereas in autosomal dominant, it was what percentage? 50%. Okay. So the diseases are metabolic disorders like cystic fibrosis, phenylketonuria, maple syrup urine disease, galactosemia, glycogen storage diseases. See, all are related to the metabolic system. Hematological disorder like sickle cell anemia and thalassemia, hereditary hemochromatosis, HFE gene mutation, neurological disorder, Friedreich's ataxia, Wilson disease, enzyme deficiencies, Tay-Sachs disease, hexosamine A deficiency, metachromatic leukodystrophy, aryl sulfatase A deficiency, leading to progressive demyelination. Skeletal and connective tissue disorders, alkaptonuria, again it is enzyme deficiency. Alice van Creveld disease, it has quite a lot of structural defects. Endocrine and renal disorders like congenital adrenal hyperplasia, then autosomal recessive polycystic kidney disease, very rare. Then alpha 1 antitrypsin deficiency, again enzyme related deficiency. Carter-Jenner syndrome, definitely an exception of autosomal recessive, where a structural defect is there. Dyne arms are defective, leading to situs inversus, chronic sinusitis, infertility. Then spinal muscular atrophy because of SMN1 gene mutation. Important is consanguinity increases the risk because of autosomal recessive genes coming together and in higher chance. Carrier screening is important in this disease. Why? Because you can stop a, a, next generation from getting affected. There is a heterozygote advantage that carriers of some autosomal recessive disorders have selective advantages, like these patients who have sickle cell disease, they are resistant to malaria because they do not have a which factor? Which factor? What is the Duffy factor? Anyone? Duffy factor is present on the RBCs and is required for the malaria to gain entry inside the RBC. So when the Duffy factor is absent, they will not get what disease? Malaria. Okay, in sickle cell disease. Now coming to X-linked disorders. Gender-based disorders. Why? Because XX is a female, XY is a male. Now, for example, if there is an X-related disorder and X, now again there are X-linked dominant and X-linked recessive, but the genes are on the X chromosome which get affected. If a mutated gene is present and still manifests as a disease, it is called X-linked dominant. And if a X-linked recessive is there, then you will need both the X chromosomes to be diseased, just like the recessive disorders. A 4-year-old boy has difficulty standing from a sitting position, enlarged calf muscles, and a waddling gait. Serum CK is markedly elevated. What is the most likely diagnosis? NM1?
Duchenne muscular
Duchenne muscular dystrophy. It's a X-linked recessive disorder and leading to this. Can anyone tell me why it is not anything else? Because the presence will be like that only, no? Becker's, Duchenne, spinal, myotonic. Why did you say Duchenne only?
Proximal muscle weakness is specifically seen in Duchenne.
And the onset is very early in life. So he's just 4-year-old boy. In 4-year-old boy, usually you will have Duchenne. Becker is not as severe. Becker is mild. Spinal muscular atrophy and myotonic dystrophy, they will present later in life. Okay? This is important. A 9-year-old boy with hemophilia A presents with recurrent episodes of hemarthrosis. His sister is asymptomatic. What is the genetic basis of this condition?
X-linked recessive.
X-linked?
Recessive.
X-linked recessive. Can you make that out from the question itself? That it is a recessive disorder because the sister is asymptomatic.
Carrier.
Yeah, she might be a carrier. She might be normal and she might be carrier as well. Where do the boys get their X chromosome from?
Mother.
Father.
Are you sure?
Mother.
They will
Mother.
always get an X chromosome from their mother because
Mother.
Y will
मतलब
come
father
from
से
the
Y
father.
आता है sir.
Yes.
Yes, sir.
So, any boy with an X-linked disorder has got the disease from their mother. An X-linked disorder cannot be taken from the father. Father is a dead end for X-related disorders. Okay? Yes?
Yes, sir.
So, whenever this question is asked, be very clear. See, both of you answered wrong. So, X will never come from the father. Father will only give Y. So this is an X-linked recessive mutation. Hemophilia A is caused by factor 8 gene following X-linked recessive inheritance affecting males predominantly. So what are the key features of X-linked inheritance? Only the genes located on X chromosome can transfer the disease. Females have two X chromosomes, so they may be carriers, and in rare condition they may be affected. Males are usually affected since they have only one X chromosome. X-linked recessive and X-linked dominant. These are the two transmission patterns. In X-linked recessive, males do not transmit the disorder to sons, but all daughters become carriers. So males are a dead end for the male progeny, but all daughters will become carriers. Carrier females have 50% chance of passing down the mutated genes to sons and daughters. Sons will manifest the disease, daughters will be carriers. X-linked dominant affected males transmit to all daughters but no sons, because X-linked disease in a male is a dead end for the sons. No sons can get disease, even recessive or dominant. The daughters will get it from the father. If recessive, they will become carriers. If dominant, the daughters will also have the disease. Affected females will transmit to 50% of the offspring, both genders. So these are the lists of X-linked
Sir,
recessive.
can you explain that again? Transmission.
Yes. I'll draw it out for you. So X, Y, and XX. Supposedly, this is a diseased person. So X-linked recessive disorder. When I write a small a, that means recessive. When I write a capital A, it means dominant. So this is the father, this is the mother. So XX will be daughter. XX will be daughter. Then comes XY. Now, as you see, the father has not transmitted the disease to any of the son. Cannot. But both the daughters are carriers. Why? Because it's then recessive disorder. Is that clear?
Okay.
So, father is a dead end for the sons. They cannot transmit any X-related gene to their sons. Now coming to X-linked dominant. Oh, this is a gay couple. Now it becomes a normal couple. Okay. So X, Y, and XX, but it is a dominant disease. So present in the male. But let us say, how is the progeny being produced? So this is XAX, XAX, XY, XY. Again, father has not transmitted the disease to their sons. Okay? Cannot, because the X chromosome of the children is, the boys is not coming from the father. But for the daughters, half of the X chromosome is coming from the father. And because it is a dominant disorder, both of the daughters will have disease. If there is a question that in a family, only sons have the disease, only daughters have the disease. Oh, start the broadcast. If only the daughters are diseased, the sons are normal. Hello? Am I audible?
Yes, sir.
Yes, sir.
If in a family only the daughters are diseased, the sons are normal. Who is the culprit?
Father.
Yes, then the culprit is the father, because all the daughters are affected. If in a family only the sons are affected and the daughters are not affected, who is the culprit?
Mother.
Mother.
Mother. Sons are diseased, but daughters are not diseased. Who is the culprit? It is the mother. Are you getting?
Yes.
In a family, the daughters are normal, but all the sons are diseased. Who is the culprit? It is the mother. If in a family, neither the sons are diseased nor the daughters are diseased, but sons of both the daughters are diseased. Grandsons are diseased from daughter side. Who is the culprit? Let me draw it for you. Normal, normal. These are daughter, this is son. But daughter has two sons, both are diseased. But sons are normal. Who is the culprit? This is diseased, this is
Mother.
diseased.
Mother.
So it is the mother.
Yes.
Mother is
Grand-
normal.
Grandmother.
Father is also normal.
Father.
So it is the father who has no, sorry. It is the grandmother
Hmm.
who has passed on the genes to this man, who eventually passed on the genes to the daughters. In X-linked, in now I have got confused. Sorry. So we will travel at it again. Number one, only boys affected means XY are diseased. Who is the culprit? Mother is the culprit. Okay. Only girls are affected. Who is the culprit? Only the girls are affected.
Father.
So it is the father, or it can be mother also. Why? Because they have XX and it is an X-linked dominant disease. It could have come from anyone. Are you getting my point?
This is a case of X-linked dominant.
Yes. Because only girls are affected. Girls can be affected only if it is an X-linked dominant disease. Because classically, X-linked recessive diseases, when they come together, the child does not survive. Are you getting my point? XA and XA will usually die stillbirth. Usually this is what happens in the nature. Theoretically, it is possible. Okay. So for practical purpose, it is the father which is the culprit here. My question is, father and mother do not have disease, but their grandchildren from mother's side, matlab, their daughters' grandsons, they have the disease. So mother becomes carrier. This is hemophilia basically. royal disease. Did you get it? This is very important to understand. When the grandchildren are affected, that means, and nobody in the parents are affected. What does this mean? One generation is skipped in case of X-linked recessive disorders. I will clarify it if you ask. If you don't say anything, I feel then you understood.
Sir, please repeat.
Great. So what I'm saying is the lady is asymptomatic. The man is also asymptomatic. No symptoms. No symptoms. They marry, and when they marry, their sons have disease. Who is the culprit? Parents are normal. No sign, no sign. No symptom, no symptom. But sons have disease. Daughters do not have disease.
Sir, mother. Mother is the culprit.
And what kind of culprit is mother? Is it a diseased culprit or a carrier culprit?
Carrier.
Carrier
Okay.
culprit. So that means there must be some culprit above. So let us go above. This is the daughter of a man and a woman. So who is the culprit to have brought this daughter? How did this gene travel?
From the mother.
From the mother. You say from the mother. Yes?
Yes.
But I say it could have come from the father also. Because daughter is a carrier, right?
Yes.
So if the father is diseased, the wife is not diseased. Even then, 50% of the children the girls will be carriers. This is a carrier daughter. And if the mother is also a carrier and the father is theoretically not diseased, even then they will have 50% daughters as carriers. Are you getting my point?
Yes, sir.
So there is an equal chance of grandparents being either the grandfather is affected or the grandmother is. If the grandfather is not affected, then the grandmother is also a carrier. Because this disease does not manifest in ladies. This manifests in males only. So if there was no male in the upper generation who ever had a disease, then the disease has come from the grandmother. If the grandfather was diseased, then the answer is clear that the culprit was grandfather. He gave it to the daughter, and then the daughter had further children who had disease. Just a second. Hello. Hello. हाँ जी सामान लैन दो. Hello. Just a second. There is Zomato guy. I'll have to pick up the food. बाहर देखो बंदा आ गया. Hello. अगला बंदा फोन कर रहा है. बात समझा कर यार. मैं चीखना बेटा. Are you clear now? Yes?
Yes.
Okay, so this is the list of X-linked recessive disorders. In X-linked recessive, there is important few things that I want to tell you for examination. One is lionization. This is known as X inactivation. Now, the thing is that in females, one X chromosome is randomly inactivated in each cell. This leads to variable expression of X-linked disorders in the females. So the question will come that X-linked dominant diseases, they manifest differently in different women. What is the concept? It is called lionization. Is that clear? This question will be asked in the exam. Male predominance is seen. Males are more severely attacked due to lack of any defending X chromosome. Sporadic cases are also there, like DMD and all. Are these questions clear about autosomal dominant, recessive, and X-linked diseases?
Yes, sir.
Great. Now we come on to another big Thank you. Now we come to the another big wig of the genetics, which is trinucleotide repeat disorders. So, what is this trinucleotide repeat disorder? We know that in genes, the codons are set as trinucleotide repeat. For example, CAA, CGG. But classically, what happens is not two uh, trinucleotides, they are repeated as such. So the sequence usually changes. But if the trinucleotides keep repeating themselves, then it leads to disorders. Now, these are very important disorders worldwide, and questions are asked, and the examiner has a lot of liberty. Why? Because these questions can come from neurology, can come from cardiology, can come from another diseases as well, in which these trinucleotide repeats, and they can twist the question so that it conforms to genetics and to the related subject also. So this is expansion of trinucleotide repeats. Common examples are Huntington's disease, Fragile X syndrome, and myotonic dystrophy. So a 35-year-old man develops progressive involuntary movements, irritability, and memory impairment. So there are involuntary movements, there is irritability, and memory is poor. His father had similar symptoms in his 40s. He is just 35. And his father had similar symptoms in 40s. What is the most likely disease? So the answer is progressive involuntary movements. It is chorea usually. So what does this patient have? Huntington's disease. So in Huntington's disease, it is important that you understand that this patient in question is 35 years old. His father had a disease when he was 40 years old. So what we have is
Anticipation.
anticipation. So as the generation goes down, the age also goes down. So younger age group will present with the disease. This is presence. It is an autosomal dominant disorder, and there is a CAG repeat in the HTT gene leading to chorea, cognitive decline, and psychiatric symptoms. So young people who were absolutely normal earlier, but suddenly started to develop coriform movements. You've ruled out basal ganglia disorder. You've ruled out rheumatic fever. You ruled out Sydenham's chorea. Suddenly, the patient of chorea starts to have behavioral abnormalities. Oh, cognitive decline has occurred. Patient has started behaving abnormally. So this means that the patient has a Huntington's chorea, and usually they are autosomal dominant disorder. 7-year-old boy, developmental delay, large ears, long face, macroorchidism. Genetic testing reveals CGG report. Repeat. What is the diagnosis? What is the diagnosis? Okay. If you don't know the diagnosis, no problem. Just try to rule out the options. Can it be Klinefelter syndrome?
No,
Wonderful. Why no?
because Klinefelter syndrome, uh, this problem with the secondary sexual characters, this should be present.
Okay, fine.
Mm,
So will Klinefelter syndrome have developmental delay?
developmental delay, no.
No. So one thing is out. Down syndrome, can it be Down syndrome?
No, no.
Why not?
Facial
Because
features are not matched.
so the long face will not be there. Macroorchidism also is not there. They have microorchidism.
Yes.
Developmental delay is there, but large ears are not there. So Down syndrome is also
So
out.
this is Fragile X syndrome, sir. This is also
Yeah,
not
this is
Turner syndrome.
yes, yes. So can it be Turner syndrome?
No.
No. Why not Turner syndrome?
This female phenotype, this Turner syndrome, female phenotype, and also enlarged breast, not at this age is not appropriate for Turner syndrome.
Okay. Fine. So the answer is by exclusion, Fragile syndrome, and the genetic testing has revealed CGG repeat. So basically, if you need to remember the macroorchidism with long face, these are classically seen in Fragile X syndrome. So this is most common inherited cause of intellectual disability caused by CGG repeats in FMR1 gene. Okay, very important Fragile X syndrome, very, very important. So let's see what are the trinucleotide repeat disorders. As I told you, trinucleotides usually don't repeat. So whenever they happen, they lead to expansion of specific trinucleotide sequence disorders. Usually in CAG, usually in CGG. CAG is Huntington's, CGG is Fragile X. The degree of expansion. Now, it is also very important. The number of repeats will define the anticipation. For example, there are just two, if there are just two repeats, that is CAG, the disease might manifest at 40 years. Let us say now it is CAG, oh, sorry, CAG, four repeats are there. This person might manifest at 20 years of age. So the higher the number of trinucleotide repeats, earlier the presentation. So degree of expansion influences the severity and age of onset of the disease. Is that okay? What is the reason for anticipation? It is the number of repeats, the degree of repeats. Is that okay?
Okay.
So key features are that these are dynamic mutations. The number of repeats can increase across generations, a phenomena called anticipation. So higher the number, earlier the age group. Greater repeat expansion lead to earlier onset and severe disease. So these are dynamic mutations. Then the mutations, they can have pathogenic, can have loss of function. For example, expanded repeats that disrupt a gene expression, for example, in Fragile X, or they can enhance the function. How? It is called toxic RNA. इतना ज्यादा कैग रिपीट हो जाएगा, इतना ज्यादा mRNA बन जाएगा कि there will be more proteins formed, leading to, for example, myotonic dystrophy. So gain of function. There will be so many muscles formed because of the multiple repeating portions, that mRNA is longer and the mRNA produces more protein. So gain of function can occur, leading to protein toxicity. For example, Huntington's disease. Mutant proteins, they aggregate. Why? Because the CAG repeat will produce an mRNA for translation. The mRNA will continue to produce that abnormal protein again and again and again, and the clumps will be formed, eventually damaging the tissue. So protein toxicity, gain of function, loss of function is the most common problem with the genetic diseases. But imagine if somebody has a gain of, I mean, the child becomes a Hulk. So myotonic dystrophy will happen. Okay. Then there is known as repeat threshold. Below a certain number, repeats are normal and stable. So that means if lesser number of repeats are there, the patient may not have any disease at all. Above the threshold, they become unstable and lead to disease. For example, Huntington's disease, the gene is HTT, CAG expansion in exon 1. Repeat threshold is 36 repeats. That is, whenever more than 36 repeats happen, the disease will happen. chorea, dementia, psychiatric disturbance, usually 30 to 40 years, 50 years. Spinocerebellar ataxia, multiple CAG expansions are there, just like Huntington's disease. Progressive ataxia, dysarthria, tremors are there. Then Fragile X syndrome, FMR1 gene, and it is CGG expansion, and the threshold repeat is 200 repeats for full mutation. If there are more than 200 CGG repeats, the disease will happen. And if the higher number is there, then earlier age group will manifest. Intellectual disability, large ear macroorchidism. Same for myotonic dystrophy, DMPK, which is CTG expansion. So more than just 50 repeats. You don't need more genes, just 50 repeats are enough, leading to myotonia, cataracts, cardiac conduction defects, insulin resistance. Friedreich's ataxia, FXN, GAA expansion is there. Only 66 repeats are needed. More than that will lead to manifestations of ataxia, cardiomyopathy, and diabetes. Important concepts to understand are: number one, anticipation. So, higher the repeats, earlier the age group, and increased in severity. Parent of origin effect, paternal transmission, diseases like Huntington tend to expand more during spermatogenesis, whereas myotonic dystrophy expansions are more likely coming from mother. So, maternal transmission, M for maternal, M for myotonic dystrophy, they are coming from mother. These are parent of origin effects you can find out. Testing and diagnosis, PCR and southern blot are used to determine the repeat size. So you not only need the repeats, you also need to know that if it is more than the repeat threshold. Prenatal testing is possible for at-risk pregnancies. Is that clear for CAG, these trinucleotide repeat sequence diseases? Yes?
Yes, sir.
Great. Now coming to large abnormalities. So we are going from small to big to another big, and now chromosomal abnormality. So these result from either structurally abnormal chromosome or numerically abnormal chromosome. So either the number is defective or the chromosome is defective. For example, Down syndrome, Turner syndrome, and Klinefelter syndrome. These are the three big wigs of chromosomal abnormality disorders. So let's see. There is a child who is born with hypotonia, upslanting palpebral fissures, a single palmar crease, a congenital heart defect. Karyotype shows 21 chromosome repeated 3 times. Trisomy. What is the recurrence risk of future pregnancies? Very good question. I think this has already come in exam. What is the recurrence risk for Down syndrome? This is trisomy 21, no?
Hmm.
So it depends on the parental karyotype. Why? Because we know that there is a Robertsonian translocation that happens. So most cases of Down syndrome are sporadic. But if it is caused by Robertsonian translocation, then the recurrence risk will be present. So it depends on parental karyotype. What kind of karyotype is there in the parent? So you cannot define it by 1, 10, 25. It has to be depending on the parental karyotype. That what type of parental karyotype has been there. A 16-year-old girl has a short stature, webbed neck, primary amenorrhea. She is found to have 45X. There is no Y, there is no second X. What is the likely diagnosis? We all know that. What is the answer?
Turners.
Turner syndrome. All right. So, Turner syndrome is caused by complete or partial loss of one X chromosome with typical features: short stature and gonadal dysgenesis. Sorry for my bad. I told the earlier disease of Marfan syndrome as tall stature, usually short stature. Okay. What are the chromosomal abnormalities? Either structural or numerical, leading to developmental, congenital, or clinical syndrome. So it is very important. In my MRCP exam in PACES, I think I got Williams syndrome. He was a short-statured guy. He had a murmur of aortic stenosis, and there was some kind of murmur which I could not define. It was, then the examiner told me it was pulmonary stenosis. So these are so commonly, they'll find out and keep such a case in the PACES. Chromosomal abnormalities, they can lead to developmental, congenital, or clinical syndromes. Types of chromosomal abnormalities can be numerical. For example, aneuploidy. Aneuploidy means either, aneuploidy means all the chromosomes should be present in an even number. You have to remember that. Only Y chromosome is by right, it is aneuploid, because Y will always be alone. No, you cannot have YY. You can have XY or XX. So X can be aneuploid or X can be normal. Normal means two chromosomes. So usually the chromosomes are two only. If they become three or they become one, that means if they become odd. In English, the word odd is odd. In mathematics, odd means one or three. But for chromosomes, odd is odd. They cannot be, normal. An odd chromosomal count is abnormal, either one or three. So aneuploidy is gain or loss of a chromosome. Trisomy is a type of aneuploidy where there are three chromosomes. Monosomy is that there is only one chromosome. Polyploidy is just try to multiply this 3, 4, 5, 6, etc. Structural abnormalities can be balanced translocation, which is known as there is no loss or gain of genetic material, that is Robertsonian translocation. For example, if somebody had a Down syndrome with 21 chromosome, three types, but the third chromosome is a bland chromosome, there is no genetic material on that third chromosome 21, then they will be totally normal people, although they have Down syndrome configuration karyotype. Is that okay? Are you getting me?
Yes.
So if they have because the chromosome has two limbs, right? If on one limb there is a genetic material, but on the other there is no genetic material, then there will be 50% manifestation. That is why certain Down syndrome people, they are very good at mathematics and music. See, this is a chromosome and this is the genetic material. So Robertsonian translocation means this patient has, this is trisomy 21. But in one patient, there is a bland chromosome, but in other, there is a genetic material present. In other, there is only half present. And in other, there is all clear. So this will be full Down syndrome, this will be partial Down syndrome, this will be no Down syndrome, although they have 20. Because Down syndrome is a clinical syndrome. Syndrome means manifestations. So people with Robertsonian translocation, in which there is no genetic material on the 21st chromosome, which is the third chromosome, then they may be just normal. They will never know that they have Down syndrome. Unbalanced translocation is where there is gain or loss of genetic material. Deletions, loss of a chromosomal segment, for example, in Cry-Du-Chart syndrome. Duplications, duplication of a chromosomal segment. Inversion, reversal of a chromosomal segment. Upar wala niche, niche wala upar. Pericentric includes a centromere. Paracentric, centromere does not get duplicated, but other things are there. Ring chromosome is when the chromosome forms a ring due to deletion of the ends. They are sticky ends. On the ends of the chromosome, there is a cap so that they don't stick to others. But if the cap is absent, they will stick to others and form a ring chromosome. Common chromosomal disorders are trisomy 21, which is Down syndrome. It can be 47XX plus 21 or 47XY plus 21. Females and males, both of them can have Down syndrome. Intellectual disability, flat facial profile, congenital heart defects, increased leukemia risk is there, very important. Then trisomy 18, Edwards syndrome, rocker bottom feet, microgonathia, congenital heart defects. Again, male and female both can be there. Trisomy 13 is Patayu syndrome, which has cleft lip palate, polydactyly, severe intellectual disability. Both males and females can be diseased. It's a 13th chromosome trisomy. Turner syndrome is just one X, other X is either absent or functionally inactive. So it is a short stature, web neck, primary amenorrhea, coarctation of aorta. Karyotype 45X or mosaicism, like 46XX, but the other X is on one, because we know that in females, one X is technically silent. So if the technically silent wala cells are more, then it will be a Turner morphology, although there will be 46XX also available. Klinefelter syndrome, 47XXY. So there are two X. So it is a sexual chromosome multiplication. Tall stature, gynecomastia, infertility. So they will have characters from both the genders. They will be tall like males. They will have gynecomastia like females, but they will be infertile because the body doesn't understand the gender. So structural abnormalities when there are in the chromosomes, it is Cry-Du-Chart syndrome with deletion of short arm of 5, chromosome number 5. That means it looks like this. So normal chromosome looks like this, but Cry-Du-Chart will look like this. Chromosome, short arm of chromosome number 5 is not there. Features are high-pitched cry, intellectual disability, and microcephaly. Dijot syndrome, 22q11.2 deletion. So a very small segment of the 22nd chromosome is deleted. So catch 22 happens. Catch is cardiac defect, abnormal faces, thymic hypoplasia, cleft palate, and hypocalcemia. Then Williams syndrome is 7th q1123, elastin gene is lost, elfin faces, hypercalcemia, extreme friendliness, cardiovascular abnormalities. Now, how do you diagnose these diseases? So question is very important. The answer is very clear. Karyotyping is the first test that you do. It detects either numerical or large structural abnormalities. What is a karyotype? It is just like a X-ray. It is just like this CT scan or an angiogram. It is basically a photo negative of chromosomes. So it detects all the chromosomes are clearly visible in it. So karyotyping is the first test nowadays routinely available for all the defective number or structural. So it cannot detect genes, but it can use structure and number of the DNA. The chromosomes can be defined. Then is FISH. FISH will identify microdeletions. Now from larger scope, I'll draw it for you. So if the understanding is at this level, this is karyotyping. So if this is the microscope and you focused it here, so you are just analyzing this part here, then it is FISH, because it can tell you deletion also. If you go even to this level, then it will become chromosomal microarray analysis, detects some microscopic duplication. Then, of course, prenatal testing is there, where you take out fluid from the amniocentesis, chorionic villus sampling, and non-invasive prenatal testing, which is NIPT. Clinical implications: these children can have developmental delays, congenital anomalies, reproductive issues, all of them can be there. Do you want to do mitochondrial inheritance in this class or in next class? We can do, we have time.
Okay, sir. Good.
Yeah. So mitochondrial inheritance, when conception happens, that is fertilization, you have to remember that the sperm only donates genetic material to the ovum. This is the ovum. This is the sperm. Once they fuse, only the genetic material will go inside. Rest everything will remain outside and dies. So that means the mitochondria are inherited from the mother. So this is 100% maternal inheritance. Maternally inherited. So these conditions, mitochondrial inheritance, some diseases were found that were present in the mother and in all the children, the sons, the daughters. So it was so difficult at that point of time to understand what kind of inheritance is this. This is not X-linked. This is not Y-linked. This is not autosomal. This is not autosomal dominant. This is not autosomal recessive. Then with the advent of electron microscopy, they could actually define that the mitochondria have their own DNA, and this mitochondrial DNA is transferred from the mother. Everybody who is listening to me, I am speaking, I have my mitochondria which have been gathered from my mother. You all have your own mitochondria which you have got from your respective mothers. So fathers have nothing to contribute as far as the mitochondria inheritance is concerned. Why do we say mitochondrial inheritance? Because mitochondria, they themselves are individual organisms which by the grace of God and nature have been imbibed into the human cell and into the all the eukaryotic cells. It's a symbiosis we live in. So they are literally algae living inside us. So they have their own DNA. This is important because if they have a disease, they will manifest in a particular lineup. So maternally inherited common examples are MELAS, which is mitochondrial encephalopathy, lactic acidosis and stroke-like episodes, and Leber's hereditary optic neuropathy, LON. Okay, a 25-year-old man presents with bilateral vision loss. His brother and mother also have similar problems. What is the most likely inheritance pattern? So this is classically mitochondrial. This is basically hereditary optic neuropathy. So everybody is blind in the family. So mitochondrial. Leber's hereditary optic neuropathy is a mitochondrial disorder characterized by optic nerve degeneration and bilateral vision loss. A 15-year-old girl has recurrent strokes. She's just 15 years. What is the age? 15 years, only 15 years. Class 10th. Muscle weakness and elevated lactic acid at all the time. Her mother also has similar symptoms, but his most likely diagnosis is MELAS, mitochondrial inherited encephalopathy and stroke-like lactic acidosis and stroke-like episodes. What are the key features of mitochondrial inheritance? So mitochondria and thus mitochondrial DNA are inherited exclusively from mothers. The proportion, both males and females are affected, but only females can pass the disorder to the offspring. Again, male is a dead end because male sperm will have the mitochondria from mother, but that mitochondria will not enter into the ovum. Heteroplasmy, each cell contains many mitochondria. So you don't know which mitochondria is diseased, which may carry a mix of normal and mutated mitochondrial DNA. The proportion of mitochondrial DNA, if it is more, then it definitely will lead to more severe disease. High energy demand tissues, which have more mitochondria like heart, like brain, muscles, they will be affected more. Tissues with high energy needs are most affected. Why? Because they have more concentration of mitochondria in them. Examples of mitochondrial disorders. Neurological is Leber hereditary optic neuropathy. Symptoms acute or subacute vision loss, usually in young adults, then MELAS, stroke-like episode, seizure. Problem can be identified by doing muscle biopsy, which shows ragged red fibers. Then myoclonic epilepsy with ragged red fibers, MRF. Again, myoclonic seizure, ataxia, dementia, young age presentation, ragged red fibers on muscle biopsy. Everybody in the family has it. Muscular disorders, Kane-Serre syndrome, very important. Progressive external ophthalmoplegia, pigmentary retinopathy, cardiac conduction defects. I have seen one family, onset before 20, very poor condition. Chronic progressive external ophthalmoplegia, ptosis and ophthalmoplegia, multi-system disorder like Leigh syndrome, symptoms developmental delay, hypotonia, respiratory abnormality. Onset is infancy or early childhood. Then retinitis pigmentosa, ataxia, neuropathy. So they are all basically mitochondrial disorder. How do you diagnose them? Very important. Genetic disorders, you can do karyotyping, then fish, then microarray, everything you can do. But for mitochondrial disorder, everything that will be normal. But if you do uh, these diagnoses, then you will need further proof. Multiple system involvement will lead to clinical suspicion. Once you have clinical suspicion, then get the tests. Like lactic acid will always be elevated in malas, and pyruvate will always be elevated in malas in blood and CSF. And muscle biopsy will show ragged red fibers in case of MRF and all those Leber's neuropathy. Genetic testing can be done to detect mitochondrial DNA mutation. Nowadays, it is possible. May involve nuclear genes affecting mitochondrial function. Treatment, there is no definitive cure. Treatment is supportive and symptom specific. If the patient has seizures, give them anti-epileptics. If they have optic neuropathy, just give them whatever counseling you can do. So there is hardly anything that you can do. But coenzyme Q10 and other mitochondrial cocktail supplements, levocarnitin, riboflavin, they have been shown to give some benefit. Physical and occupational therapy can be done. Points to remember is number one, it is a completely maternal lineage. Mitochondrial disorders, they are transmitted exclusively via mother. Heteroplasmy means a single cell may have multiple mitochondria. So all our mothers are reflected in us through all our mothers means mother's mother, their mother, their mother, their mother. So you can actually have all the genes from your 100 mothers. So down the line, 100 generational mothers. So all the mitochondria are there. If it has accumulated so much, the disease will manifest in a more severe form. But let us say if the mutational DNA is less, then probably you are safe, even if there are mitochondrial inheritance. There's a threshold effect. That means just like repeat threshold in case of trinucleotide repeat, that manifestation happens when the mutant DNA has got certain proportional excellence over the normal DNA. Okay, is it fine, or can we do imprinting disorders also? Yeah, we'll do imprinting disorders also. Then we will finish the class. So what is imprinting disorder? Basically, imprinting disorder means the gene is there. And how do you know that the gene is like a negative? So those who know the camera photography earlier on would have a reel. So you will take a photo, there will be a negative, and the negative will be sent to the photographer, and they will process the negative and make a photo on the paper. So that is called imprinting. Same way, imprinting disorder means the gene is there, the gene is defective, but the manifestation will happen as a protein. So the abnormal gene expression due to epigenetic modification. So they will have different photo, even if the negative was same, even if the photographer was same, even if the light was same. So, but the photo printing will be different. Common examples are Prader-Willi syndrome, Engelmann syndrome, and Beckwith-Wiedemann. Out of them, Prader-Willi and Engelmann are very important. A 5-year-old boy presenting with severe hypotonia, intellectual disability, obesity, they are fat, and excessive appetite, they eat a lot. Genetic testing shows deletion in the paternal copy of chromosome 15q11 13 subunit. What is the most likely diagnosis? So if it is papa's gene loss, it is Prader-Willi. Papa is P, Prader-Willi is P, Prader-Willi. So Prader-Willi syndrome is caused by loss of papa's gene, that is paternal copy of chromosome 15, or maternal uniparental disomy. You don't need to understand that, but just loss of paternal copy. It is characterized by hyperphagy, obesity, and intellectual disability. A 6-year-old girl has severe intellectual disability, seizure, ataxia, inappropriate laughter. Genetic testing reveals deletion of maternal copy of chromosome 15. So the chromosome 15, if the maternal copy is lost, they become angels. The girls are angels, angelic. So Engelmann syndrome reflects from a deletion or inactivation of maternal chromosome 15q11 13. So presenting with developmental delay, ataxia, seizure, and happy demeanor. What are imprinting disorders? They are basically caused by disruption of genomic imprinting, a process where the genes are expressed from negative to a paper photo. This regulation is controlled by epigenetic mechanisms. What is epigenesis? Epigenesis means the genes are there, but there are certain other controllers which are outside the genes, epigene, like other for example, DNA methylation, other processes which are involved in the DNA to protein translation process. So key features are parent of origin effect. The disease will depend on whether the disrupted or the mutated allele has come from either the father or the mother. Imprinting regions, specific chromosomal regions are associated with imprinting. For example, in 15th chromosome, it is the Q11 to Q13 segment. It is basically imprinting component. So if the maternal gene is not there, it will imprint as differently. If the paternal gene component is absent, then they will manifest differently. Causes, either uniparental disomy, means all the chromosomes have come from one parent. Both copies of chromosomal come from one parent. Imprinting center mutation means there is the imprinting signal is altered. Then, of course, there are deletions and mutations. So, Prader-Willi is chromosomal papa father gene, chromosomal 15q11 to q13 imprinting region, loss of paternal contribution usually up to 70%. Imprinting center mutation is only 1 to 2%. Features neonatal hypotonia, poor feeding. Their muscles are flabby. Their tummy is like patulous. Their tummy is like big tummy. One is that they eat too much. Another is that tummy is flabby. The muscle tone is not there, so it becomes too heavy. Hypogonadism, short stature, intellectual instability. Management, growth hormone can be given to tone up the muscles, dietary management to keep them thin and lean, and behavioral therapy, of course. As far as Angelman syndrome is concerned, it is loss of maternal contribution of Q11 to Q13 segment. Again, maternal deletion is 70%, rest of them 7 and 10. Severe intellectual disability, speech impairment, laughter, even at a smallest talk, they will start laughing, frequent laughter. Seizures, characteristic facial feature. Management, supportive therapy, anticonvulsants for seizure. There is another disease like Beckwith-Wiedemann syndrome, Silver Russell, which are 11p15 7. So not an important for us. And then diagnostic tool. How do you diagnose? There are DNA methylation issues. So methylation studies can be done by looking for methylation specific PCR. Genetic testing can be done to identify deletions, mutations, and these things. Karyotyping can tell you that some segment there's a short chromosome. Why? Because when the DNA segments are lost, the chromosome becomes shorter in size. So karyotyping can also define that there's a short chromosome. Important to understand is these imprinting disorders can have parent of origin effects, which are crucial to diagnosis, and understanding is important because both of the genes will have the chromosome will show that this 15q to 11 to 13th segment is deleted, but it will manifest in certain people as seizure girls, and others there will be boys who will be manifesting as fat, obese, hyperphagia. So why this difference when only one same segment is deleted? Later on we came to understand that one of the segment when comes from the mother and is deleted, then it behaves like Angelman syndrome. When it comes from father, they behave like Prader. Epigenetic testing, for example, DNA methylation is important. Many disorders require multidisciplinary management like endo, neuro, and genetic counseling. That is all for today. I hope it was an interesting class for you. I have tried to incorporate and tell you very important topics in a simple form. We will do the next of the topics in the next class. Have you understood everything?
Sir, one question I have
Yeah.
is for diagnostic test, whether we'll go for karyotyping or genetic testing.
See, karyotyping is number one. Whenever there is a patient in your clinic, how do you progress on the investigation? First is clinical examination. So once you do a clinical examination, you are seeing the person as a whole. Then you go on a microscopic level. Then you take your stethoscope, put the stethoscope on the heart, trying to focus and trying to localize your examination. Still, you find that you need to go further inside. You get an ECG, you get an echocardiogram. Still, you want to go inside, you do an coronary angiogram. You try to look for the vessels. Same way, when you have a doubt in mind that your patient may have a genetic disorder, you will start with clinical examination. Then take his blood test or a buccal test, and first of all check the chromosome number and chromosome shape. Is that okay? Once you've done that and you find, oh, the chromosome number is fine, the shape is fine, that means I need to go further inside.
Then genetic testing.
Then you do genetic testing. And because genetic testing word comes from gene. So you do gene testing then. First you do chromosomal testing, then you do gene testing. And in case you find that gene deletion is same, then you do imprinting testing, that is methylation studies. That, oh, the gene is absent in both of them are behave differently. Oh, one of them has come from father, the other deletion has come from the mother. This is how you keep going deeper and deeper and deeper. And then even if you find that, oh, the chromosome is fine, it is the same, and there is no deletion, fine, let me look for a nucleotide repeat. Maybe there is a gene which is having repeat. So you go from chromosome to gene to, damn it, nucleotide level. You go as down, as deep. These days you can go as down as up to histone protein level. That only depends on your curiosity and knowledge and the commitment to establish a diagnosis. So first comes karyotype, then comes gene testing, then comes electron microscopy to define the repeats and whatnot. There's so much on genetics these days.
Okay. Thank you.
Okay. Any other comments, feedback? Because genetics is very difficult. Right from the word, when I was in MBBS second year, I thought, oh, genetics, oh my God. But now I find it so interesting, because once you start to see the things clearly, you can tell your students about that. And if I may trigger interest in genetics in any of you, it will be a success. Okay. So it is not restricted to just autosomal dominant and X-linked recessive dominant and autosomal recessive. There's so much in genetics, and you will eventually come to know that the genetic basis of disease will take over everything else. There will be genetic basis of pharmacology also, so which is known as pharmacogenetics. Very soon it will be there. The patient will be treated for so many things in a gene specific manner. Chalo, that day will come. I don't know if we will be alive to see that, but that definitely will happen one day. All right, doctors, take care. Bye bye. Good night.
Thank you.